Very, very good evening, one and all. So, Thursday evening for the past 5+ years, 5.5 years, for the pulmonary fraternity across the subcontinent, Thursday evening means Guru Var ke raat, Guru ke saath. Okay, with this famous, selfless, dedicated service of spreading knowledge, wisdom, okay, um, from CCI experts, and since then CCI is doing relentlessly the webinars week after week without any break. So this week I'm truly honored to uh, present myself right in front of you on behalf of CCI as a moderator for the very needy topic, very urgent topic, and timely topic, that is cough and the syrups. And welcome one and all who has connected across the subcontinent and also from the bordering neighboring countries. And also this time, interestingly, I'll share in short while from you with you. We have a panelist, okay, who is joining from London as well. So for the last few months, India has faced one of the darkest chapters in modern pharmacology, the tragic deaths of few dozens of children linked to tainted cough syrups contaminated with diethylene glycol. So, and these were not isolated events. When we look back, similar tragedies echoed from the Uzbek, Cameroon, shaking public trust in medicines that were once household names. And this morning, our good friend Dr. Vibhu indeed shared another interesting information. Couple of decades back, the same diethylene glycol contaminated paracetamol syrup, and then there was a loss of few kids from Chennai. So that is not a new thing. Time and again, there is some amount of lack of pharmacovigilance, and there is breach of protocols, ultimately leading to contamination of the syrups and leading to death of kids. But it's our, as a national academic body, it's our responsibility to just disseminate what is truth, what is the way forward to treat the cough in the modern era. That is our duty. That's why CCS came forward to do this urgent needy topic, the cough and the syrups. And today, um, uh, we have a star-studded panel right across from India. And then, as I was mentioning, so Vibhu has a different tale to tell. But so uh, we have a star-studded panel from this subcontinent. But one of our guest is from London as well, Dr. Sakshi Singh. She's practicing pediatric pulmonologist. She did her training from Lucknow, and then now practicing with one of the hospitals in London. And welcome, Dr. Sakshi Singh. Looking forward for your valuable inputs today and in next 1.5 to 2 hours. And Dr. Aditya Aggarwal, welcome, Dr. Aditya Aggarwal, senior consultant from Sri Ganganagar. So welcome, Dr. Aditya. And Professor Dr. Ravi Dosi. What we can tell, we cannot tell anything in words regarding the warmth that Dr. Ravi Dosi exhibits. He's a phenomenal guy, great friend, one of the pillar of CCI. We are absolutely honored to have you on board, Dr. Ravi. Okay, you all know he's from Indore, Kokilaben. And Dr. Zaheer Abbas Shah, welcome.
Good evening, sir.
Yeah, very good evening. So Dr. Zaheer is joining from Aurangabad. He's a senior consultant pulmonologist from there. Dr. Rajiv RD from Dhanbad is another guest what we are having tonight. He's a well-experienced senior pharmacologist. So he is kind enough to agree to participate in our webinar. Welcome, Dr. Rajiv.
Thank you, sir.
And Dr. Vibhu. So great friend. And the beauty of Vibhu is he makes all simple things complex. Sorry, because he's not not only pulmonologist, he's a legal expert. If you would have remained as a pediatric pulmonologist, you would have made complex things simple. But he is here today taking the role of the legal expert as well. Let's look forward to listen the legal version of what is this where is this gap, and whether the Dr. Praveen Soni who got arrested, okay, what is the legal aspect behind it, and those few excerpts will listen from Dr. Vibhu. Vibhu is a renowned pediatric pulmonologist from New Delhi. Welcome, Dr. Vibhu.
Thank you, sir. Thank you, sir.
And so the flow, my dear friends, okay, please do write to us all your queries, whatever you have. Okay, please share so that we'll answer all your queries tonight. Meanwhile, the flow would be, okay, Dr. Sakshi will speak on pediatric cough mechanisms and management, and followed by Dr. Ravi Dosi will speak on adult cough from symptomatic symptom assessment to strategic management of adult cough. So without any further ado, okay, I want Dr. Sakshi to take over the stage.
Hello everyone, I'm Dr. Sakshi. I'm properly based in India, but currently in UK, currently pediatric pulmonologist in Great Ormond Street Children's Hospital, London. First of all, I would like to thank Dr. Krishna sir, Atri sir, and Vijay sir for giving me this opportunity to talk about this topic today. So I would like to briefly introduce you with pediatric cough management and mechanism and management. So why cough matters? As we all know, it is leading respiratory symptom in children worldwide. 25% to 30% of children who come to Indian OPDs come with presentation of cough. In UK, this number is even more high. It is 69% of children report coughing, which is usually associated with cold. So what is the global concern? The concern is this cough is major driver of inappropriate antibiotic and over-the-counter medicine use in children. If we look at UK data, we find that NHS data shows there is a declining trend, but there's still persisting parental demand for cough syrups. Although cough syrups are not available over the counter and they're not recommended under age of 6, so they don't have that kind of access, so they're not using it mostly. Regarding antibiotic use for this cough, it is around 8 to 10%, and these children even despite having viral infection, end up having antibiotics, but the number is only 10% in UK. If you look at Indian data, we see that 50% of children are prescribed antibiotics empirically. Over-counter cough syrup use is more than 70%, which is there in all combinations of antihistaminics, mucolytics, bronchodilators, and whatnot. Antibiotic misuse is probably driven by the diagnostic uncertainty, caregiver expectations, and easy accessibility. Like every Indian shop has cough remedy drugs. So the implications are that we are ending up having more antibiotic-resistant, irrational polytherapy, extra side effects, and caregivers' dependency on these drugs. Coming on to the cough reflex and its regulation. So as we all know that there are 3 phases of cough. The first phase is deep inspiratory, second phase is compressive phase, and third phase is expulsive phase. When deep inspiration of cough reflex starts, the afferent sensory receptors, the airway sensory receptors, get stretched, like rapid-acting receptors, slow-acting receptors, and C fibers. They communicate to brain via vagus nerve. The signal goes to cough center, which is primarily nucleus rectus solitarius, and from there, the signals from brain are communicated through efferent limb, mainly by vagus, phrenic, and spinal motor nerves to effector organs that are diaphragm, intercostal muscles, abdominal and laryngeal muscles. And that starts the compressive and expulsive phase of cough. Now, briefly coming on to modulation of cough reflex. So the cough reflex can be modulated in 3 ways. The first one is peripheral modulation, there can be central modulation, and there can be neural plasticity. The agents that act on airway sensory receptors or efferents to increase cough threshold, like menthol, it acts on TRPM8 activation, causes transient suppression of cough. Local anesthetics, which we usually use during bronchoscopy, are sodium channel blockers, and they also suppress the efferent transmissions. Inhaled corticosteroids usually act by peripheral modulation. They cause reduced airway inflammation and peripheral sensitization. Central modulation, on the other hand, alters the processing in brainstem and cortical pathways. So cortical control allows the voluntary suppression of cough or the habitual cough, whereas opioids and dextromethorphan are central antitussives and they suppress the CNS. Neural plasticity, on the other hand, is a phenomena which is triggered by chronic inflammation, where receptor upregulation occurs, leads to central sensitization. So what happens is the cough persists despite trigger resolution. That explains why cough hypersensitive syndrome occurs and how early target can control the inflammation and neural sensitization. Now, this is something which is very basic, but then it is must for everyone to know about it, that pediatric cough is different from adult cough. And the ways it is different is the reflexes in pediatric are relatively immature, the receptors are more sensitive, voluntary control is poor, expulsive force is weaker, and the clinical implication of this is it causes overall ineffective clearance of secretions, more frequent triggers, and prolonged post-viral cough. Now coming on to some cough phenotypes. So our international bodies have made a framework, have made the cough classification by various categories. It can depend on the duration of cough, character of cough, and the context of cough. So duration of cough, we say if the cough lasts for less than 2 to 3 weeks, we say it's acute cough. Subacute is a vague entity where it lasts between 3 to 4 weeks, and any cough which lasts for more than 4 weeks, it's chronic cough. By character, it can be dry or wet, and cough can be isolated and can be associated with some diagnostic pointers. Now, coming on briefly about dry and wet cough. So they have entirely different etiologies, different inflammation pathway, different investigation battery, and different clinical meaning. Dry cough is usually in pediatrics, and most commonly it is due to post-viral cough. Cough variant asthma, allergy, postnasal drip, habitual cough, and reflux are other causes of dry cough. The clinical clues to dry cough is no sputum production. They're often nocturnal, may follow URDI symptoms, or follow allergen exposure. Inflammation is usually eosinophilic or neurogenic. Investigation completely depends on the presentation of child, and therapeutic trials of short ICS can be tried if it is asthma phenotype. The clinical meaning of dry cough is usually it is taken as often inflammatory or irritative and may self-resolve. Whereas coming on to the wet cough, the causes are pretty more severe, like protracted bacterial bronchitis, any chronic infection, bronchiectasis, aspiration, and cystic fibrosis. The clinical cues for wet cough would be audible secretions, moist rectal quality, persistent beyond viral course. Inflammation is usually neutrophilic type, and the investigation battery requires to do an X-ray, sputum culture, and further imaging if it is refractory to antibiotic response. Treatment would be 2 to 4 weeks of antibiotic, depending on what it is, along with airway clearance. As we know, wet cough has to be taken out. The clinical meaning of this would be wet cough is always pathological and requires evaluation of infection and or structural lung diseases. You can't leave a wet cough. Now coming on to diagnostic algorithm. So if a child comes to you in OPD with cough, what do I do? So first we'll look at the duration and know what type of cough it is. Then we characterize the cough, whether it is a dry or wet cough. And then the mandatory step to always rule out are the red flags. So what are the red flags which we should always look in a child who comes with cough? That can be very soft symptoms like failure to thrive, history of frequent pneumonias, sudden onset, can be very overt like respiratory distress, cyanosis, apnea. They're all indicators of serious disease and needs specialist workup. Upon doing all this, then we decide for some baseline investigations depending on what the child was. And it is recommended to do all chronic cough. It is recommended to do specific and blood baseline investigations for all cough which last for more than 4 weeks. Then we come to targeted evaluation and empirical trial of therapy. So if it is wet cough, we go for antibiotics more. If it's dry cough, we would look at the causes. If it's reflux, we treat the reflux. If it's an allergy, we give antihistamines and nasal steroids. And if it is asthma, we can try ICS. But the bottom line here is the trial must be short and diagnostic. It shouldn't be open-ended. The most important step after this would be to reassess the child. So to not, even if you diagnose the cough, even if you diagnose the cause, even if you prescribe the treatment, do not forget to reassess the child. So we need to reassess this child after 2 to 4 weeks. What could be the outcome? If the symptoms have resolved, that confirms our diagnosis and we stop the empirical therapy. If the symptoms are persistent, we need to step up. We need to work up further. We need to maybe do a CT scan, a bronchoscopy, some cultures, refer to pediatric pulmonologist, because the key is to have early evaluation to prevent chronic lung disease. Now coming on to some key clinical guidelines and evidence-based positions regarding the treatment of cough. So NICE guideline in UK says, if it is acute cough, it is usually self-limiting. Do not offer oral or inhaled bronchodilators or any corticosteroids or mucolytics. We avoid using antibiotics and we should only advise for self-care like hydration, symptomatic relief rather than cough medicines. ERS also implies the same. ERS says if it is chronic dry cough, go for inhaled corticosteroid, and it emphasizes on treatable traits rather than blanket use of the symptomatic cough medicines. ERS strongly recommends not to use any over-the-counter cough syrups for chronic cough. The other evidences also suggest the same. So most guidelines say to not use over-counter medicine, do not use even prescription cough medicines, only go for honey, 1.5 teaspoon before bedtime for children more than 1 year of age with viral upper respiratory infection related cough, because honey can be given to more than 1 year child who is mostly post-viral, and we have got evidences for that, but it can't be used below 1 year of age. As we know, there is a risk of botulism by the use of honey below 1 year of age. Now coming on to the management, if we have got cough, what all can we do? So we divide it as supportive measures and some target-specific therapies. So for supportive measures, these are the first line for all cough types and can be given to all coughs as a first line. Like we use saline nasal drops for irrigation. It improves the mucociliary clearance, improves the postnasal drip, and it is safe for all ages. We can use some humidification. Honey can be used in age more than 1 year. Adequate hydration has to be maintained. And we avoid over-the-counter cough syrups and antitussives below 6 years of age, because we don't know what the efficacy is. There is high risk of side effects like sedation, respiratory depression, and overdose. We should also avoid use of PPI until unless we know it is reflux disease. That's what ERS says. Now coming on to the targeted therapy. If it is PBB, we know we have to treat with 2 to 4 weeks of antibiotic, mostly homoxicillin, If it is asthma, we have to go for inhaled corticosteroids, bronchodilators. If it is allergic rhinitis, we go for antihistaminics and nasal steroids. For pertussis, we go for macrolides. For GERD, we go for positioning, PPI. For habitual cough, we go for behavioral therapy. Now, the WHO recommendations. So WHO is emphasizing on it a lot and has been issuing advisories in past and now as well regarding cough syrups. I would like to briefly touch upon that. So regarding antitussives, WHO says not recommended in children under 12 years of age and is absolutely contraindicated below 2 years. Expectorants are not routinely used in any age group. Decongestants, contraindicated below 6 years, has got very cautious use in children between 6 to 12 years. First generation antihistamines are contraindicated below 6, and second generation can be used for allergic rhinitis if the child is more than 2 years of age. The combination cough syrups, which are very widely available everywhere in India, kindly avoid multi-ingredient formulation in all children. So the key points from my talk would be treat the cause, not the cough. Reassessment is really important. If you treat a child with cough, kindly reassess after 2 to 4 weeks. Avoid empirical polypharmacotherapy and educate the parents. In pediatrics, it's really important to talk to parents and educate them about the natural course, the warning signs, and safe home remedies, which should be honey. Thank you for your patient listening. Now I would like to hand over to Dr. Ravi Dosi, sir, for further talk.
A very good evening to all of you, and a big hello on my part. I'm Professor Dr. Ravi Dosi. I come from Indore. I would like to thank Dr. Sakshi for that brilliant illustration of pediatric cough and talking about cough in general. I would like to thank Dr. N.H. Krishna sir, Dr. C. Vijay Kumar sir, Dr. Atri, Dr. Shivani, Dr. Kirat, and Dr. Narayan Pradeep for this kind opportunity on talking on a very important topic which is visited, revisited, although for various reasons. I would like to talk today about managing cough in adults. Well, cough not far away. We had that time when whenever you used to see people coughing, then we were afraid that, oh, if that guy is coughing, it might be COVID, it might be H1N1, it might be some bacterial infection, and it might be TB. Well, it is a fact. Cough is a risk factor for the spread of infectious diseases very commonly. Not only that, but intense cough results in various sinister complications like hoarseness, urinary incontinence, syncope, vomiting, musculoskeletal pain. It can even cause rib fractures, hernias, sleep disorders, headache, exhaustion. It can cause severe relationship problems between couples, and it can cause depression in almost 50% of patients affected with chronic cough. Chronic cough has also led to traffic accidents. Cough is of several severities which can be fluctuating daily. The intensity daily, it can impact the patient's daily activities or sleep, which can be reported with the help of several available visual analog scales and cough symptom scores. We need to target the management of a patient individually. We need to tailor the patient's management depending on the patient's history, his or her clinical, chemical, and physical examination. We need to identify red flag signs which are very important as far as any patient is concerned, be it adult or pediatric, and we need to train the general physician regarding identification of those red flag signs, which is very, very important. Well, the cough pathway, though already has been illustrated, is very important in adult cough management also, because it is on the basis of the afferents which are situated in the lung, larynx, airway tract, diaphragm, or the efferents which are there in the several vagus nerve, phrenic nerve, and spinal motor nerve, and the several receptors which are situated there, that all of the coughs related medications work. Three important nerves, vagus nerve, glossopharyngeal nerve, trigeminal nerve, are involved in the cough reflex, and there is also the role of the phrenic nerve. Now, cough is a important reflex. It is also called as watchdog of the respiratory system. It has an initial inspiratory cough phase followed by a cough peak expiratory flow, and then that is the classical cough pattern. This particular airflow pattern of inspiration followed by a forceful expiration is what basically is responsible for the cough mechanism. Whenever a patient of adult cough comes to you, we need to divide it grossly into respiratory and non-respiratory causes. The respiratory causes can be again divided into their duration on the basis of acute being less than 3 weeks, 3 to 8 weeks, or chronic being more than 8 weeks. If it is productive, it is wet cough. If it is dry, it is a non-productive cough. The red flag signs which are to be seen very importantly are if the patient is dyspneic, tachypneic, he is having thoracic pain, any tachycardia or wheezing is there. In subacute cough, we have to see if there is vomiting after coughing or if there is that loud whoop which is there. And in chronic cough, the most important red flag signs are those of fever, peripheral edema, nasal stuffiness, dyspnea, heartburn, hemoptysis, orthopnea. If there is associated sneezing or wheezing, if there is associated weight loss gain, post-nasal drip, or hoarseness of voice. Well, we need to simplify cough categorization. For that, there are several questionnaires available in which there is a look at the cough, whether it is productive, dry, consistency of the expectorate, amount of the expectorate, color of the expectorate, the red flag signs which I just described. Are there triggers like is there smoking, occupational history, medication history, allergies? Are there comorbidities like diabetes, hypertension, cardiac disorders, lung disorders? And what is the final impression? Depending on that, we need to further manage the patients. In acute cough less than 3 weeks, you take a detailed history. Most important is see whether it is infectious or non-infectious. If infectious, try to localize and identify the organism like acute bronchitis due to viral etiology, bacterial etiology, tuberculosis, or is it an upper respiratory tract infection of viral etiology? Non-infectious causes may present with exacerbation of underlying diseases like asthma, bronchiectasis, or COPD. Chronic cough is what is the major part of referral to chest and adult physicians. Usually, there is a multitude of etiology of chronic cough, which you can see in this slide. There are very many reasons involved, but one of the few important reasons which I would like to highlight is cough hypersensitivity, on which most of the medicines work. You can divide it into several causes, but the most important in chronic cough that we need to rule out are asthma, upper airway cough syndrome, GERD, COPD, bronchiectasis, and in some cases where there are risk factors, lung cancer needs also to be ruled out. Whenever you have a patient of acute cough, you need to take a detailed medical history. You do need to take a proper chest X-ray, and you need to rule out the life-threatening causes. What is very important is life-threatening causes like pneumonia, like COVID-19. We got a few years ago. Currently, it might be influenza, severe asthma exacerbations, COPD exacerbations, pulmonary embolism, CHF, and foreign body aspiration, which may happen in adults also. Now, the most common causes of subacute cough, that 3 to 8 week is the post-infectious category, which we commonly get in pneumonia, bronchitis, and post-viral bronchitis. Non-post-infectious causes of subacute cough usually include acute exacerbation of chronic diseases of the lung. In subacute cough, again, it is important to take a proper history and get a chest X-ray, see the red flag signs. We should have a look at whether it is a post-infectious cough. Have we been able to identify any organism or not? Or is it an exacerbation of asthma, bronchitis, COPD, GERD, and bronchiectasis? And we need to tailor-make the treatment to the patient accordingly. Now, if the patient is still crossing that 8 week criteria, first have a look at the X-ray. If the X-ray is normal, it can be a GERD, asthma, cough variant asthma, non-asthmatic eosinophilic bronchitis, upper airway cough syndrome. It may be a smoker's cough. It may be medication related or ACE inhibitors may be there, or it may be vocal cord dysfunction. But if it is an abnormal X-ray, then be on the lookout for things like a malignancy, diffuse interstitial lung disease, COPD, CHF, and bronchiectasis. There is a very detailed algorithm, but what is important is investigations are needed, proper medical history, and it should all start with an X-ray. Now, there is a common thought that chronic cough, shall we go for a CT scan straight away? Well, clinicians should not perform a CT scan in patients with chronic cough. If it is a normal X-ray and physical examination, we should first try to evaluate for other causes. Whenever we are taking up a patient of chronic cough, it is very important that we see the duration, impact, family history, cough score. We initially manage by stopping all the potential risk factors, initiating corticosteroids or LTRs, particularly when phenol blood eosinophils are high. And you should initiate PPI only when peptic symptoms or evidence of acid reflux is present. Well, if there is improvement, then we should continue for 3 months. But if there is no improvement, then there are several other tests like high resolution esophageal manometry, induced sputum, laryngoscopy, bronchoscopy, and that is when we should think about chest CT. If there is no improvement, there are several agents like low dose opiates, pro-motility agents, gabapentin, pregabalin, or cough control therapy, which can be advised. More common other causes of chronic cough are lung cancer, cystic fibrosis in adolescent group, chronic bronchitis in which sodium bromoglycate can be given in the smoker group, and ILDs in which perfenadol may have a relieving role. Patients who are smokers, we should remember smoking is a major remediable cause of chronic cough and is linked to COPD. There is a direct relation between the amount of smoking and the cough severity, and smoking history and current cigarette consumption are predictors. There are two important varieties of chronic cough variant asthma, in which all the lung functions are normal. They improve after bronchodilators, and the response is reevaluated after 4 weeks, in which oral steroids up to 40 milligram prednisolone can be used. Then you have non-asthmatic eosinophilic bronchitis, in which you have a chronic cough with eosinophilic inflammation. One more very important cause is GERD associated cough seen in pregnancy, late night obesity, smokers. They have several symptoms like sore taste in the mouth, regurgitation of food, and the cough is more of a dry nature with a lumpy throat. You need to treat them with PPI like pantoprazole, lansoprazole, omeprazole, and you have several other H2 antagonists and prokinetics. Upper airway cough syndrome is an important reason. Pharmacological management is empirical. We should do nasal washings and give up intranasal corticosteroids with first generation antihistaminics. Iatrogenic cough is one important cause in which angiotensin 2 receptor antagonists should be substituted in case of ACE inhibitors. Then bisphosphonates and calcium channel antagonists may cause chronic cough by dilating the lower esophageal sphincters, and the eye drops containing prostaglandin analogs can also cause cough. There is this unexplained cough. You can't explain anything. It can be attributed to a syndrome called cough hypersensitivity syndrome. It has been attributed to deregulation of neuronal pathways like the TRP receptors, TRPA1 and 2. It is associated when there is an increase of menopausal symptoms, depressive syndrome, and autoimmune disorders. And it is this where we have to use slow release opioid malformations, nearly 5 to 10 milligram twice daily in adult patients. Opioids are the only thing which are worth using in this cough hypersensitivity syndrome, followed by some newer available drugs like pregabalin, which can be given up to 75 milligram twice daily. P2X3 receptor antagonists with gefapixant being the main active agent have been proven of benefit in chronic refractory cough. Gefapixant is used in doses of 45 milligram twice daily with side effects of dysgeusia, nausea, upper respiratory tract infections. After gefapixant, a newer antagonist by the name of camlipixant is also available. Non-pharmacological therapy like physiotherapy, speech pathology treatment is also indicated. It is not recommended to do pheno blood eosinophil count rapidly. If your patient is having asthmatic symptoms, a subacute cough, then you can go a anti-inflammatory or bronchodilator trial for 4 weeks. But if it doesn't work in 4 weeks, then you should definitely reevaluate. Routinely, PPIs and HT antagonists should not be given for treating chronic cough patients. Pro-motility agents, again, if there is a suspicion of GRD, then only they should be given. Otherwise, they should be avoided routinely. In chronic refractory cough, low dose, slow release morphine of 5 to 10 milligram is the drug of choice. And non-pharmacological therapy should only be instituted when you have effectively ruled out all the other causes. In children, antibiotics may be recommended, but in adults, it is still a questionable practice to give antibiotics, although it is rampant hugely. There are several other newer drugs which are on the horizon, like a substance P antagonist by the name of orvepitant has been studied in phase 2. But these P2X3 receptors, which I mentioned, the purinergic receptors, are those which are most hopeful, and it has been recommended that antihistamines have a very important role to play in this particular group. But as we all know, the most important and the most commonly used remedies in dry cough are those of honey, ginger, steam inhalation, warm gargles, herbal teas, turmeric milk, onion and honey syrup, lemon honey mixture, eucalyptus oil and hydration. Almost practically everybody comes after using this only to you. So we should be careful. There are several non-specific therapies like pharyngeal demulcent, depressants, expectorants, bronchial secretion enhancers, and mucolytics which are available. And more astonishingly and surprisingly, there is a combination of all of these also available. There are several antitussives available like opioids, non-opioids, antihistaminics, peripherally acting antitussives like prenodiazepine and bronchodilators. Well, there is a combination of all of these particular tussive, antitussives along with nebulized lidocaine. You have locally acting anesthetics like benzonatate also which is available. What is important is we have to carefully balance our decision of giving a particular expectorant antitussive. Giving combinations is a very risky business because actually you'll be giving medication with two different physiologies. In lung cancer, the cough becomes very difficult to manage, so palliative care specialists use this particular role of opioids very vastly in cough control, which is very important. What is important is we should always try to first take a proper history, identify what is the particular cause of the cough in this patient, what is the trigger, and third step, if the patient is not controlled with a proper treatment, then only we should prefer going to control of cough hypersensitivity with antitussives and non-pharmacological therapy like speech language pathology treatment. Thank you very much for your patient listening, and I would like to hand it back to Dr. C. Vijay Kumar sir for carrying forward the webinar. Thank you.
See, totally appreciate Dr. Ravi Dosi and then Dr. Sakshi for such a wonderful talks, which set actually the tone for the webinar. And then really appreciate both of you. And just in addition to Dr. Ravi Dosi, so I sometimes develop some psychological cough. Okay, so myself, what I do is I use clove. Okay, you have not mentioned that the home remedy which I can add for your talk. So meanwhile, okay, let's welcome one and all again. So beautiful star-studded panel. So next one and a half hour, we are going to have back-to-back questions. My request to each one of you is be crisp. Okay, try to be to the point. Already there are 20-25 audience questions have come. So we have already preset close to around 20-25 questions to handle. So let's be very to the point. So Rajiv sir, so first question to you. So what are the most common classes and combinations of cough syrups that you come across, and how many truly have evidence backing them overall?
Yes. Yes, we actually, we have all the kinds of combinations. In the dry coughs, basically dextromethorphan and chlorpheniramine with or without phenylephrine, the decongestant, are actually seen, as well as there is a new drug, peripheral antitussives, levodopa with chlorpheniramine, which are safe for children more than 2 years old. These combinations are very used. And for the productive cough, there is ambroxol and bromhexine combined with the guanfacine and terbutaline with menthol. These combinations are very commonly, but evidence-based, if you say dextromethorphan, yes, it is an NMDA blocker and sigma-1 and antagonist. Agonist, but dextromethorphan is very cautioned for used in children, so it should be always used more than 6 years. But we know in clinical practice we see dextromethorphan combinations are given in most of the chemists to the children even. So yes, there is codeine, there is levodopa. There are evidence-based. They are very good. Guanfacine is FDA approved. We are using it very commonly. And there are many antihistaminics and decongestants are like only phenylephrine we use. There are, there are also combinations of some Ayurvedic treatment also in many of the, but as such, evidence-based, we have very few, but in practice, there are many things we encounter in our daily practice.
Yeah, thanks for that very quick response. So basically, we have antitussives and then expectorants. So you have nicely summarized them. So over to Dr. Aditya. How do you clinically handle patients? Sometimes what they come is, by the time they reach you as a pulmonologist, they will be coming to you with a expectorant, with a antitussive, and also some anti-reflex. So many combinations. Okay, is there a what rationale you practice in deep prescribing these medications, and what is the thought process behind you?
Yes, sir, definitely, sir. Usually, sir, when a patient comes to us with the multiple over-the-dose counter cough syrups, usually it is a sign of frustration. Usually, a patient says कि डॉक्टर साहब बहुत खांसी के सिरप ले लिए ठीक नहीं हो रहे, and they usually have a fragmented care history if we take it clearly. So my first step, which I usually take, is I reframe the conversation. I validate their experience, which is very important to gain the trust of the patient. And then I try to understand the underlying mechanism why the patient cough has not been suppressed. Whether is it due to inflammation, or is it something neurogenic, or there is something behavioral, or else so and so. Because usually most of the over-the-dose the counter syrups are non-specific suppressants, as clearly explained very well by sir. So they are oftenly usually combined with either antihistaminics or a decongestants or a de-emulsants. So basically these are all non-specific suppressants. So my next step is then to rationalize the medicine. I actively de-prescribe the unnecessary combinations which are there, especially if there is a polypharmacy, or if we say there is a no clear benefit to the patient. And then my approach next thing is to introduce a treatable trait, which is very important to see why the cough is, whether it is due to an airway inflammation or a reflux sensitivity, or we say whether there is some laryngeal dysfunction or so and so. Basically, the rationale behind the approach is to move from trial and error to a targeted intervention, which is very important in building a patient trust, and often it leads to better outcome. So in nutshell, if I say a clinician should de-prescribe OTC cough when there is no clear diagnosis, when the combination is not justified, when the patients have symptoms persistent despite using multiple agents, or when the treatment lacks some objective reassessment, or there is no endpoint of this.
Aditya has clearly mentioned, very clearly mentioned. Okay, of course, Dr. Sakshi also in her conclusion statements, she mentioned very clearly, treat the cause of the cough, not the cough. So that's very important. So identify the reason behind it and ensure that you treat the reason for the cough, patient will get better. Now, after that wonderful talk, Dr. Ravi Bhai, okay, may I call upon you for your input on, we see a lot of fixed drug combinations like dextromethorphan, chlorpheniramine, guaifenesin, phenylephrine. So they are all probably, if not trillions, at least $billion business they are doing in India. Okay, are these combinations clinically justified or simply commercial constructs?
Well, sir, it's very difficult to answer this because they are all ultimately there in the market, and if they are in the market, they have gone through some regulatory body. So till they are there, they will be used because people find coughs so distressing. And like most of my patients, the first person treating the cough is the medical wala, and then your neighbor, and then it is the doctor. You will be number 10. Before that, they will be consuming all of them. So the problem is these ingredients, you have given me a combination dextromethorphan, this diphenhydramine, guaifenesin and phenylephrine. You will be surprised to know, sir, that officially 3 of these combinations, that means the use of dextromethorphan, guaifenesin and chlorpheniramine is actually banned by Government of India. So they just remove one component, add one and launch it in the market by seeking the help of regulatory and law limitations. But we as physicians, it is our duty to be really careful. Why? Because there are conflicting effects of these ingredients. One is a suppressant, another is an expectorant. They work just opposite to each other. There is very limited evidence of the dosage and combined usage of these substances in clinical practice or in academia. So if you fall into a soup, you have literally no literature to refer to. And the biggest problem is with suppressants. the effect that they have on the GIT, the effect that they have on the mental status, it is very difficult to assess that. And biggest thing, since there is low lack of academic proof, anything goofs up, then you have nothing to back on. So I would personally prefer to be more cause specific rather than going for these combinations.
Again, you're the third one you're hitting on. So treat the cause of the cough rather than cough with this illogical combination of medications. So 100% agree with you. So let me move on to Dr. Zaheer. So Zaheer bhai, so please let me know. So there are once you write, even as a specialist, you write a prescription of cough syrup. So what happens? The patients is they go back. They use you write one bottle because over the counter anything is available in India. Let me be very honest. I know I'm talking on a public forum. So you manage the pharmacist. You can get any cough syrup without prescription. So in such scenario, so what is your experience and what is your take on what's the abuse potential of these cough syrups, and then what are the drug-drug interaction potential, especially in those cough syrups where you have codeine on one hand and also antihistamines simultaneously in the same syrup.
So, good evening. At the outset, I am very much thankful to the founder president of CCI, Dr. N.H. Krishna sir, and the whole team of CCI for making me a part of this webinar. So, coming to the abuse potential of the different formulation which we are having in the market. So, we are having these opioids are there, dextromethorphans are there, and promethazine is there. So, if we are speaking about these, they are having high to moderate potential, abuse potential. Only thing is that the chlorpheniramine is there, which is having a mild abuse potential. And whenever we talk about this major drug-to-drug interaction, for speaking about this codeine formulation, when it is combined with the benzodiazepine, when taken with the benzodiazepine or alcohol or barbiturates, so they are having this CNS depressant action and additive CNS depression is there. Now, coming to this dextromethorphan, when these are taken with the MAO inhibitors or linezolide, so there is a serotonergic effect is there, and hyperreflexia will be there, tachycardia will be there. So seroepiatrine, it will actuate or accentuate this hypertensive crisis. Guafenicin is safer, and chlorpheniramine maleate will, if it is taken with the alcohol or sedative, so excessive sedation, there is a chance of excessive sedation and impaired cognition will be there. So this is my take on this abuse potential and this major drug-to-drug interaction, sir.
Yeah, brilliantly put. Okay, all these illogical combinations, and of course, you have mentioned rightly, some other drugs lead to so potential toxicity worsening. So, my dear friends, okay, when we are prescribing, okay, as a physicians, it is very important to let our patient be aware that when you have this syrup, okay, try not to, at least drive, okay. So, or at least, which requires those jobs which requires a lot of attention, they should not be performing. So that's what. And I now call upon Dr. Sakshi. Okay, that was a fantastic, brilliant show. So wonderful talk on pediatric cough. I learned a lot from your talk, Dr. Sakshi. So thank you for sparing time from the UK. So, in my question to you is, okay, in children, there are a lot of multi-combination syrups are available. So many of them, when we prescribe as a clinicians, as a experienced clinicians, we prescribe. Okay, even we feel very safe. Okay, what is your take on this? And then how do they pharmacokinetics and metabolisms actually compare? And how safe is to, you have mentioned this slightly in your talk. Okay, just to reiterate and then explain the same, please let us know whether they are safe or not. I think your video is cracking. my simple suggestion is please switch off your video and then speak.
First of all, I would like to thank the full CCI team for having me today. I know it's a very big platform to be speaking on.
Okay. Am I audible, sir?
Yeah, you are audible.
Okay.
Please go.
First of all, I'm very thankful for the whole CCI team, including you, sir, and NH Krishna, sir, and everyone else for inviting me here today. It's my anonymous platform. Coming on to your question. First of all, children are not all adults, and children are really immature, and so the drug clearance is really slow and unpredictable. When we mix antitussives, antihistaminics, decongestant, mucolytics, even paracetamol in one bottle, all those drugs compete for the same enzymes. That leads to metabolic saturation and accumulation in the body. Especially under the age of 6, these enzymes are really immature, and we shouldn't be experimenting by giving multiple drugs combination. Further on, these central antitussives, especially, and first generation antihistaminics, they cause real CNS depression. And in infants, the blood-brain barrier is more permeable. It is a leaky kind of barrier, not a proper barrier. So what happens is, even if you give a small dose of central antitussives or first generation antihistaminics, they directly reach the brain. They can cause sedation, seizures, apnea, encephalopathy, and may lead to coma as well. So that's why we are really scared and we are really reluctant to try these central antitussives and first generation antihistaminics, especially in children below 2 years of age. Dextromethorphan, as Zaheer sir has already mentioned, that it causes real respiratory depression and CNS depression, and he has talked already about pseudoephedrine and chlorpheniramine and these drugs. So I won't be repeating myself. I would only like to say that it causes extra hepatic load, and our international regulatory body, WHO, and even IMNCI says that we should avoid all the multi-component cough and cold formulation in children. Thank you.
Thank you so much for reiterating whatever you have mentioned in your talk. Really appreciate. And now, Dr. Vibhu, okay.
Yes, sir.
Remember, something is legally required. You're there.
So what we need to understand, as Dr. Sakshi also mentioned,
Right.
I mean, we need to understand a very simple line that children are not just small adults. So
Right.
with the respect to the cough reflex and the neurobiology, we need to understand that there are different thresholds which are there. There are developmental constraints which are there, as Dr. Sakshi also mentioned, that the blood-brain barrier is different. And there are different but common etiologies. And another thing is, as you mentioned that you have some amount of psychogenic cough, which we normally don't see in case of the children. So we need to see that the things may look quite similar, but they're not so. And as far as the psychogenic cough is concerned, I would like to put a point across that we have started seeing those kind of issues now in our teenage children, which we never used to see in children. Now we've started seeing, not exactly teenage, I would say pre-teenage, around 10, 11 years old. So somewhere down the line, I think we do have a lot of overlap, but we need to understand that the responses are different, the development is different, and the body is different. So there we don't need to consider, okay, by only the dose adjustment of the adult can be done in case of the children. That is not so.
So my question was, okay, is there any, regulations are robust enough to prevent their misuse?
So one thing is that let me be very clear that
for us as a legal expert. Right.
No, so legally, I'll be very clear. So as far as the Drug Regulatory Authority in India is concerned, most of the cough syrups are banned below 5 years of age. Let's be very clear on that. And as far as there are certain like cetirizine is allowed above 6 months of age, but then there are there is hyoscine which is allowed above 3 years of age. So we do have some age-related regulations which are there. And I think your question actually is basically because of the case of Dr. Praveen Soni, where he has been accused of giving a drug which is not really recommended for small children.
Right.
But I think Dr. Dosi very clearly mentioned that if it is there in the market, it is going to be sold. Now tell me one thing, how do you justify a simple cough syrup with the combination which Dr. Sakshi was saying, illogical combination of chlorpheniramine, phenylephrine with paracetamol and everything. You have that cocktail available in drops form. Now that's available in the drops form because that is recommended for the children below the weight of about 10 kgs. So if it's 10 kgs, which means you are giving it to children who are at least less than 2 years of age in India. Normally, 10 kg you cross by the age of 2 years. So it's available means somewhere down the line, the regulatory body. So I think there's a lot of confusion which is there. So to keep ourselves safe, we should know what are the molecules which we can give safely. And personally speaking, I would say, I was reading through a few of the questions are also there. So I was going through it. And I think Dr. Rajiv had spoken about certain drugs which are available as Ayurvedic stuff and the natural stuff. So the hydration therapy and natural stuff is more acceptable legally as compared to the pharmacological stuff, because when it comes down to pharmacological stuff, we are very clear you can't give it below this years of age, while in case of the so-called natural drugs, they are considered to be kind of more or less safe. So I think we can go towards that. If we want to give a cough syrup, if you have to give a cough syrup or you have to give a cough drop, then I think it's better to go for the natural stuff. Like I always say, go for hydration therapy.
We need to be very clear here, Vibhu. So because natural stuff or Ayurvedic stuff does mean it does have some chemical, and which we don't.
No. When I say natural stuff, it means hydration therapy दे दिया आपने. ठीक है, घर पे काढ़ा बनाकर आप घर पे काढ़ा बनाकर दे रहे हैं. आप यो यूजिंग घर पे आप जो है वो लहसुन सॉरी अदरक जो है उसको आप पेस्ट बनाकर you're doing something with that. I mean, when I say natural, I really mean completely natural at home remedies.
I agree to your point, but again, not an Ayurvedic preparation, because
not an Ayurvedic preparation. Sorry, I think
so, which may have some toxic compounds.
Definitely.
Right.
Definitely.
So thank you. Thanks.
I like to add like tulsi drops, turmeric, like golden milk. That turmeric and tulsi. These are like common household products, and they can be used as such. And some steam can be given to the they're very low for the children. So yeah.
Thank you, Rajiv bhai. So meanwhile, we have plenty of audience questions. So whatever we have covered, I'm not going to ask. But again, really appreciate Dr. Jaswant Singh Panwar from Madhya Pradesh, Dr. Ashok from Madhya Pradesh, Indore, Dr. F.A. Chaudhary from Madhya Pradesh, Dr. Nidhi Mittal from Madhya Pradesh, Dr. Hemraj Yadav from Madhya Pradesh, Dr. Koyal from Madhya Pradesh, and Dr. Khan Amir Kausar from Maharashtra, Dr. Tanzi ul Alam from Kolkata, and Dr. Ramesh for your active participation. So anything which we are not covering, will definitely going to take your questions. Please keep shooting your questions. So coming to Dr. Rajiv sir. Okay. So for you, okay, what is the evolving pharmacological understanding of cough hypersensitivity syndrome, and how do this P2X3 antagonists like gefapixant? I know Ravi has touched briefly. Can you please explain? Unmute yourself. Unmute.
I'm so sorry. Earlier in the old variety, like in old Harrison, you see this chronic idiopathic cough, and it is like or chronic hypersensitivity syndrome. So now, like the like two new editions, I've seen the same term. Basically, what happens, it is already mentioned by our esteemed faculties before. It is because of the inflamed epithelium, the peripheral drivers, the peripheral sensitization. So what happens, it is an enhanced response. It is typically an enhanced response of a cough reflex to a normally innocuous stimuli, like a normal, For example, as I say, suppose an inflammation is there, a laryngitis is there. So there will be release of ATP, protons and all. It will act on the P2X3 receptors, which are present on the afferent vagus nerve, which will go to the NTS in the cuff center. And then there will be, like a motor response or a cuff. So when, P2X3 is a pulmonologic receptors, and we have some trials going on, the phase 3 trials going on for some drugs. But one thing I want to say in this particular format, that there are basically the cuff hypersensitivity syndrome is more or less right now we are focusing on a sensory neural disorder. So it is a sensory neural disorder and have some peripheral drivers like P2X3 and TRPV1 and TRPA, and some central circle like NTS and periaqueductal gray matter. So there is decrease or reduce descending inhibition. So there will be more of cuff response for a normal stimulus, like suppose just a fragrance or some temperature change, or some talking and laughing. So the period is around more than 8 weeks. We, as such, in a gist we can say. So, and about the P2X3 receptors, we are still very evolving. There are 2 to 3 drugs which are in the phase 3 clinical trials.
Right.
I think.
So, is this drugs available for the use in India?
No, right now, DCGI has just given in August 2025 also, and before also to a company, they have approved for the phase 3 clinical trials. They are present in USA, they are present in US, in a European Union, in the Switzerland, and as well as in Japan. But right now in India, they are still in the phase 3 clinical trial.
Right. See, I cannot ask the same question to Dr. Sakshi because Sakshi does pediatric pulmonology. I'm sure these drugs are not approved in pediatrics. Any comments briefly, Dr. Sakshi?
No, sir. These drugs are not at all approved in
That's
pediatrics.
it. Right. Thank you.
Basically, the entity of cough hypersensitivity syndrome does not exist in pediatric population. We have seen these entities mainly in late adolescent period, which are transitioning towards adulthood. So it's not an entity of pediatrics. So usually we are not looking for these drugs. So we don't use it.
Thank you.
And also it is present more in women than men. It's written in Harrison. So in an older woman, maybe. Yeah.
Thanks for bringing the reference as well.
The older one.
So to Aditya, okay, what does this BTS and ERS guidelines, how they have reframed chronic cough as treatable traits, and these treatable traits, okay, as per the guidelines, do they have any impact in pulmonary practice, and what impact they can bring in clinical practice?
So basically, if we look at the in a chronic cough, which is like 10% prevalence is there. In the previously, if we look, there is an anatomical triad was there. Like if the patient has a chronic cough, we are looking for an upper airway cough syndrome, or we are looking for an asthma, or we are looking for a GRD. So this approach often led to delays in the diagnosis, and empirical treatment was given without any response, and usually the overlap syndromes are missed, which is true for nowadays. If we see, there is a multi-morbidity is there is phenotypic overlap is there. So nowadays the concept of treatable trend is there, and it is a mechanism based treatment is given, multi-dimensional approach is there, and personalized treatment is there. For example, if a patient has an airway eosinophilia, or patient has a laryngeal hypersensitivity, or patient might have a reflex hypersensitivity, the cough could be there, or there can be some central cough hypersensitivity, which we are discussing nowadays. So what it means is a more targeted approach, a faster and patient-centric approach. So the treatable traits often facilitates earlier symptom control, and it reduces unnecessary medication exposure like prolonged use of any cough syrups or a PPIs or like this, and it improves quality of life through precision-based care. So in short, we are shifting it from a modifiable, treatable thing to ultimately what matters to a patient.
So you want to mention that there is the probably we can all start precision cough clinics. So that's what the way forward. So over to Dr. Ravi Dosi. Dr. Ravi, okay, please let me know how do you differentiate in your OPD practice or in IP practice? So refractory cough, how do you differentiate from unexplained chronic cough and then refractory chronic cough, and how do you deal in your practice?
जो ठीक नहीं होता है, that's chronic cough, sir. That's very difficult, and really those patients are very tough patients, sir. But very frankly speaking, you need to take a very thorough history, which includes even your environmental and occupation related factors and your personal history involving your addictions and personal habits. There has to be a thorough physical examination, which needs to start from general to respiratory to a multi-system examination. Then usually in respiratory cases, we tend to examine airway hyperresponsiveness first. We tend to see for spirometry, their sputum cytology or fractional exhaled nitric oxide first. That is what we as pulmonologists prefer to. But if the thing doesn't get solved over there, we don't get an etiology, then we go for physically examining the upper and lower airway. We go for a nasal endoscopy, a laryngoscopy, and if required, a bronchoscopy under light sedation. So these are the usual methods. And finally, if we are still inconclusive, we go for assessment of gastroesophageal reflux diseases. If we are able to localize something, then we have a cause of chronic cough. Not responding to treatment, you call it refractory chronic cough. And there is a 60 to 40 ratio over here. Usually the common conditions like asthma, allergic rhinitis, and gastroesophageal reflux diseases. In chronic cough, usually you will see that these are the etiological agents, but they respond very poorly to their standard treatment. Then there is that entity in which you have done everything as per the protocol, but still you're not getting any answer. That is when you have that, we don't know what is the reason, unclassified chronic cough. It is very frustrating for the patient because of the battery of tests is invasive, but still that is how I go about diagnosing these coughs.
What do you do in this unexplained chronic coughs? What is your take?
Sir, basically, unexplained chronic cough, ultimately, all the pharmacologists and pediatric pulmonologists are talking about neurological mechanisms. So, in my personal practice, in adult practice, even I have got patients of that 18 to 25 group in which I have actually evaluated everything and have come to the conclusion that they are suffering from some psychological issues, particularly, like told by my colleagues, teenage population definitely is having this thing of some psychogenic cough, and I am taking the help of psychiatrists and counselors, and they are responding to that therapy, sir.
Thank you, Ravi Bhai, for that clarity. So probably cognitive behavioral therapy, talking to them, explaining them. See, sometimes what happens is there may be some psychological disturbances, during the childhood, during the growth phase. So these kind of things have to be really, taken into consideration. And then it doesn't mean that unexplained chronic cough doesn't mean that there is no treatment. There is a treatment. Empathetic approach from the clinician end is majority of times it works, and put them on to a psychologist, make them talk, and then make them express whatever is there psychologically. And then probably these are the patients where the latest one like Gefapixant, all those things may work. I don't know. Right. So, Dr. Zaheer, so how do the airway disease like asthma and COPD overlap with cough hypersensitivity, and where does one stop and where does the other begins?
Sir, first of all, cough hypersensitivity syndrome is not a disease and it's a pathophysiological mechanism. So in what happens in CHS, there is a heightened sensitivity to the cough reflex cascade, and which can be triggered with the trivial stimuli as well. So what happens in the cough hypersensitivity, there is a neural hyperresponsiveness we know, and in OADs like asthma, COPD and eosinophilic bronchitis, there will be airway remodeling will be there, inflammation there will be there, there, and airway hyperresponsiveness will be there. So most of the time in overlap, what happens is chronic airway inflammation in obstructive airway disease can sensitize the airway nerves and leading to hypersensitivity. Most of the time, the cough, CHS, there will be cough will be the predominant symptoms, and in asthma and these OADs, the wheeze and dyspnea will be the presenting symptoms. But what happens in the overlap? So there will be this overlap will present like the cough will be the predominant symptom as we see in the cough variant asthma. Now coming to the inflammatory cell, as we know, there are variable cells. They may be involved in the CHS, but eosinophilic inflammation will be there in the asthma and eosinophilic bronchitis, and the neutrophilic inflammation will be there in COPD patient, subset of patient. Now what happens in this overlap? So cytokines will be the variable cytokines like IL-5, IL-13 will be released in the circulation. When coming to the spirometry will be normal in this curve hypersensitivity, and there will be obstructive pattern in the OADs. And if there is an obstruction, it clearly suggests OAD phenotype. And if it is normal, then it is a pure CHS. Now drawing a line between this phenotype and comorbidities. So we do have this cough variant asthma. So in this, the patient will nicely improve with the help of inhaled corticosteroid, or he will react to this, and this inflammation will be clear cut under control. What happened with the comorbidities? So this like CHS, the asthma will be controlled, and this obstruction will be well controlled, but the patient's cough will not respond to these remedies, and they can respond better to whatever we are having. These neuromodulators are there, so they will respond to this. So this is my take on this whole question, sir.
Thank you, Dr. Zaheer. So over to Dr. Sakshi. You briefly touched upon the cough hypersensitivity as well. So can you please elaborate what is your experience with how the infections playing a role in pediatric spectrum, and then how far do you believe that hypersensitivity can be seen in pediatric age group? You have commented, but again, please explain in detail.
So in children, over 80% of the chronic cough has a very clear organic cause, whether it is inflammation, infection, or any airway disease. This is so typical that ERS 2020 guidelines very clearly mention that cough hypersensitivity syndrome is not applicable to children. It's not typically seen in children, and their cough are usually treatable. And also these children have very immature inhibitory control. So they have a cough reflex, which is more reactive, I would say, but then they are very reversible. They are not in the spectrum of cough hypersensitivity syndrome, where they have a sensitization and they are not responding and they are very prolonged. And coming on to the cough hypersensitivity syndrome, it is seen in older adolescents nowadays, as Vibhu so very kindly focused on it, that nowadays we see teenagers where they have psychogenic cough. So yes, we are seeing psychogenic cough now increasingly these days, especially in UK population. They have this very fancy psychogenic cough a lot. But coming on to the chronic, the cough hypersensitivity syndrome, it's more of an older adolescent thing rather than a pediatric thing, I would say. They don't have a sustained C fiber upregulation kind of thing, which we see in adults. The hypersensitivity response in children is very, very transient, and it is related to peripheral hypersensitivity during the infections, not after that.
In your practice, okay, yeah, what is the predominant cause or top 1, 2, 3 differentials for a cough that is persisting beyond 4 weeks in pediatric age group?
So if the cough is persistent beyond 4 weeks, then again, I would say, as we go very stepwise approach, we have seen the differentiation. We'll differentiate if it is a dry cough or a wet cough. If it is a dry cough, we'll see and look at the phenotypes. Looks like allergic, looks like asthma, looks like reflux disease, and we approach according to that. If it is most likely, usually it fits into asthma kind of spectrum, then we try some ICS inhalers. We go for proper workup of spirometry, and we do pheno and those bits. And if it is in the wet cough spectrum, then we go more for antibiotic treatment. And then we are very much interested to know what the cause of the cough is. We try to bring out the sputum, we send cultures, we do CT if needed, if the child is not responding to antibiotics of 2 to 4 weeks. But I would say we are very much targeted, and we advise for being more targeted rather than doing a blanket therapy for everyone. So we go stepwise. It is dry, wet, whatever, and then approach it accordingly.
Again, I'm getting very clear statements from you. So please identify when it is turning into chronic. Okay, please identify the cause. Okay, no blanket treatment,
Yeah.
particularly no cough syrups.
No
Please.
cough syrups, please.
No cough syrups. Right. See, Vibhu bhai. Okay. See, again, any comments you want to add for whatever Dr. Sakshi has contributed?
So I think the practice is quite different in UK as compared to in India, because here the issue is that we do get a lot of cough syrups which which have the combinations. So another thing which we need to understand is, like, it's easier said than done. We have regulations on the cough syrups, but we all know that none of these cough syrups are actually being sold strictly on the basis of the prescription, except for, I think, the codeine and some dextromethorphan combinations. So codeine is also because the reason is the drug inspectors have a lot of pressure over them. So the chemists have to sell them and keep a track of who is the prescribing doctor. Otherwise, if you see, because I see adults and the children both. So in adults, if I give codeine, it's very easy, but in children, I cannot give. But coming to the simple cough syrups, I think it becomes very different as far as India is concerned. So like ma'am said, वहाँ पर first you do the phenotypes, you do the entire investigation, and then you approach. Probably in India, it's quite different and difficult too, because we have to understand the parents are not at all that patient in India as compared to probably the English patients. So if your child is like, I'll tell you my example. Yesterday, I had a patient in the morning at around 12ish times. I gave that patient a course of antibiotic and anti-allergic. And I received a call at around, I think, 6 p.m. that my child is still coughing. It is better, but it's still, doctor is just about 50% better. You've given, and I've already given 3 doses, and the child is not well. I mean, imagine the kind of desperation parents have, because the main issue is we need to understand, as pediatricians, when the children cough, they vomit also. तो वो पेरेंट्स के लिए एक एक्स्ट्रा बड़ा एक बहुत बड़ा एपिसोड हो जाता है. द चिल्ड्रन इज नॉट ईटिंग एंड द चाइल्ड इज वॉमिटिंग टू. So it becomes a bit of an issue. So I think in simple words, what I can say is that whatever we are speaking, no cough syrups and all, it's easier said than done. So what is important is, as CCI, we should push for, whoever is listening today, that whatever cough syrups you are recommending, they have to be safe. You have to be legally safe. Both the things have to be there, that you have to be legally safe. So there may be a cough syrup which you feel is absolutely safe, but that is not recommended for that particular age. Please don't do that, because currently what we are seeing is shooting the messenger. That's what we have seen, and that's what has happened with the recent case. And I think that's a kind of a learning for me too, because till now, I never thought that this kind of a thing is there, because if we go by the law of the country, the law of the country is not that way, that you can just arrest a doctor like that. And here the doctor really doesn't have much of a issue. Fine, he may be doing his private practice or whatever, that's a different issue. But the thing is available, as Dr. Dosi also mentioned, that the regulatory authorities allow a lot of things in the market. So now you need to understand whatever is there in the market, wahan se bhi you have to pick and choose and then only give. And so I would say what Dr. Sakshi says, Dr. Dosi said, and everybody here says, humko mix and match karke. In India, we have to practice in a very mixed and matched kind of a way.
Right. Thank you. Thank you so much. Over to Dr. Rajiv. So, sir, can you please throw some light on what are the various cough syrups that that we can prescribe in?
So we already discussed.
Yeah.
So we already discussed these questions. Like,
No problem. Thank you. But at the same time, so it is very, very difficult to be responsible for whatever the what do you call, instead of the contaminants. Okay.
yes,
So for doctors, it is not a job. Okay, our job is to prescribe an approved medication, but a contamination, as Dr. Vibhu rightly mentioned, it is not a responsibility. But again, as Vibhu clearly mentioned, hope you also agree with that. Okay, whenever there is a gray zone, try not to venture into it, particularly in prescribing pediatric cough syrups. That's what I want to say. So
yes,
coming
sir.
to Aditya, so Dr. Aditya, please mention how effective are these cough control therapies like speech therapy or breathing retraining in refractory cough cases.
So, sir, definitely. When I have ruled out all the other causes of cough, like an allergy or an asthma or an obstructive airway disease, these therapies take a central role in effective care of the patient. I initiate these therapies very early once all these therapies are rolled out, usually because these patients who have a psychogenic cough, or we say mindfulness like cough, so they have a typical tingle or they have an urge to cough without a clear trigger. There is no trigger. Patient wants to cough. So
Right.
simply that's where the behavioral approach is very important, and that's where the role of cough control speech therapy, or we say targeted laryngeal behavior therapies, do play a role in such. I am very fortunate, sir. We have a Anvidyalaya in my town in Sri Ganganagar, where we have a speech pathologist, and also we have trained psychologists over here, which I am closely working with in such patients, because we have a lot of patients of these 20 to 25 years of age nowadays coming with these symptoms without any trigger. So I closely work with them, and I properly prescribe them with these therapies. So usually it helps in training the reflex. Often there are very impressive outcomes are there, and studies have also shown that the response to these therapies are there is up to 70%, because there is a sensory hyperreactivity with this. Secondly, which is very important, is cognitive behavior therapy or mindfulness therapy also plays the role when there is some patient who is associated cough with anxiety, or there is some somatoform disorder is there, or some hypervigilance is there specifically. So
Right.
these patients have a central gain, and patient might have a cough perception bias in such patients. So the key and the very important thing is to multidisciplinary model in such patients, and unnecessary adding any drugs will not help in such cases, and then the multidisciplinary model will help them in such a patient.
So I do notice, Dr. Aditya, what happens in there is I'm sure you are well aware of this um, EDAC or ECAC. So expiratory dynamic airway collapse or excessive central airway collapse component. Okay, these kind of patients, when we come across, it is very, very important to tell them that if you can control your first cough, okay, then the subsequent cough episodes will be under your control. So it is very, very important. If they initiate the cough, what happens is then they will have rounds of coughs, continuous bouts of cough will be there. So these particular things, okay, we have to be meticulously address, look into precise points. I exclude everything before saying that speech therapy or breath training, retraining is needed. But again, in my experience says that in probably around 10 to 20% of cases with refractory coughs, these kind of therapies do work miraculously. So, over to Dr. Ravi. Ravi bhai, so please let me know. Okay, do you ever depend on pheno? Okay, that is particularly a value more than 25 parts per billion. Okay, do you assume in these refractory cases as it's a surrogate marker of cough variant asthma, and then you try on inhaled corticosteroids, or you prefer neuromodulators? And what is your take on pheno?
Well, sir, Pheno is an excellent tool, I would say, sir, particularly as far as the justification of using inhaled corticosteroids is there in escalation of therapy of inhaled steroids is there. So, if you have a patient who is coughing and has a high Pheno, then that chronic cough, you are justified to give him a 3 to 4 week trial of inhaled corticosteroids. If it doesn't work, go for a leukotriene receptor antagonist along with, or you can even go for oral corticosteroids because it is showing it is a Th2 airway inflammation is there, so you are justified in giving steroids. Now, reverse also, sir, if your Th2 is low, if Pheno is low also, then also you have a justification if cough is not responding to use higher dose of steroids for a shorter period of time, just on a trial basis. So both ways, I feel it gives us some idea. At the same time, sir, neuromodulation, sir, see, problem with neuromodulation is the like centrally acting drugs like morphine. So morphine, even if used in 5 to 10 milligram BD doses, has some amount of cough suppressing activity which is postulated.
Right.
So in patients who are having Th2 inflammation, if they are bringing out expectoration, using neuromodulation might be counterproductive. Though
Right.
there is no RCT saying that this happens, but still theoretically it may be counterproductive. One very interesting point is that in patient with refractory chronic cough, even with normal spirometry, normal X-ray, normal CT, even if you use cough suppressants, they don't have any additional advantage. The inhaled corticosteroid will still fare almost better or at par with them only. So I think Pheno rules and Th2 inflammation and steroids are still bread and butter for us.
See, I agree completely with you. Only one addition is sometimes we do come across significant elevated levels of Pheno to the tune of 60, 70, even beyond 100 in GERD related cough. That's a caution. The false positive high levels of Pheno. So where you may miss, for which what I do in my clinical practice is whenever we are looking at the CT scan, CAT scan, so the lower esophageal sphincter, whether it is dilated or not, is one thing which is a surrogate marker in clinical practice where this can be potentially because of GERD-related cough rather than the elevated Pheno is not because of T2 high inflammation. Thank you so much, Ravi bhai, for that wonderful input. So over to Dr. Zaheer. What's your stance on using gabapentinoids or low-dose morphine for chronic cough? I'm sure Dr. Ravi has just commented.
Yes.
Your opinion, please.
So half of the answer has been already given by Dr. Ravi Dosi, sir. So,
Yes.
sir, ERS 2020 guidelines. So it clearly mentioned it has a strong recommendation for using this cough neuromodulatory agents like opioids, morphine. So it can be used in at a dose of 5 to 10 mg BID in adult patients. So he forget to mention about this adult patient, and that too in the cough that is refractory. So chronic refractory cough. So this is about this opioids or morphine. Now coming to the pregabalin or this gabapentin. So the ERS 2020 guidelines, it mentioned it has given conditional recommendation because it is having itself, these products are having their own side effect, dizziness, drowsiness, dry mouth will be there, fatigue and nausea will be there. So that's why and the blurred vision is the side effect, main adverse effect of this gabapentin and pregabalin. So that's why they should be used very cautiously.
So again, I agree with you 100%. But again, there is a very, when you identify a cause, so please treat the cause of the cough. Okay.
Yes.
And then root cause analysis, very important. So these morphine or gabapentin can potentially suppress the cough, but if it is as a lost result only, not to go upfront.
Yes.
So agree with you. Thank you, Dr. Zaheer.
Yes.
So, Sakshi ma'am, see, please let me know, okay, how do you tackle antibiotic misuse in pediatric cough? You have just few minutes back, you have mentioned clearly that you can give antibiotic trial for even 2 to 4 weeks. So that is something I felt it is somewhat weird. 4 weeks of antibiotic, I don't think we should give without any evidence. But And what is your take on it? And especially in the scenario where Dr. Vibhu was clearly mentioning, so for cough, the parents of the kids, they expect a syrup. So your take on it?
Yeah. So I would say that, as we all know, that in pediatric, cough is the most common reason why children get antibiotic, first of all. And we also know that cough in most cases is viral or post-viral, and it is self-limiting, almost in 70 to 80% cases. But the real driver for the prescription of antibiotic, I would agree with Vibhu sir in this, that these parental expectations for a syrup and clinician time pressure. Like, you have to heal this cough in 2 days. You have to heal this cough in 3 doses. This is the real pressure which we as clinicians are facing here. And as we all know from my presentation, that I have said that half of the children in India are getting antibiotic prescription for their cough. In UK also, you're getting 10% antibiotic prescription for viral coughs, so which is less than what it is in India. The reason for that would be more over-the-counter availability of drugs in India rather than that they are in UK. So that would be one thing. And to tackle the situation, I would again re-emphasize on we should go stepwise clinical approach. First, classify cough. And regarding the antibiotic therapy I mentioned, I was very clear in mentioning that we should only prescribe antibiotics in wet cough which lasted for more than 4 weeks. Because here, when we see a cough which lasted for more than 4 weeks and it is a wet cough, we always think there is some kind of infection. It can be PBB, the protected bacterial bronchitis thing. It can be some chronic suppurative lung disease where child is proceeding. It can be cystic fibrosis. It can be pulmonary PCD. So these kind of scenario where there is some issue with the mucus clearance and secondary infection, which is leading to the whole complication of the situation. That's where we would like to have a trial of antibiotics. And I would say it should be very short, precise, and targeted. 2 weeks to 4 weeks is what the standard treatment for PBB we are giving here and everywhere in world. So that's where it came from, that we should be trying 2 weeks of antibiotics. That would be very clearly amoxicillin clavulinate, which we try. And after that, if the cough is not responding, we have to look into more details of what the cause can be. So the bottom line here is we have to treat the wet cough, which is for more than 4 weeks, or a documented bacterial infection like pneumonia, sinusitis, pertussis. In those cases, we have to clear, but you have to treat with antibiotics. Sorry, you need to say it. The other bottom line is communication with parents. I think pediatrics is all about having good communication with parents, no matter what the disease is. If it is cough or it is cancer, you have to talk to parents what it is. So I would say, as you very correctly mentioned, that we need to have some empathy when we talk to the parents, because they have already, in India especially, even in UK, they have already been to many places before they come to us. So we need to follow, I would say, a 3E kind of rule where we should have empathy with the parents. We should start with this, that yes, we understand what you're going through. Yes, we know your child is in trouble. Yes, we understand this cough is really bothersome and your child is not able to sleep and he's vomiting. And then the second step would be to explain them what exactly is happening with their child. So we'll have to take some time to explain them what exactly is happening. If it is a dry cough, tell them it is most likely viral, it is post-viral, it will go away in some time. Don't deny them treatment. That would be, I would say, the third E. Just empower them. Empowering would be in the form of, as all of us have been emphasizing, that we should give them something. And then that something would be honey if the child is more than 1 year of age. We can go for some fluid like hydration, as Rajiv sir and everyone almost said that we should give well hydration. We should do some steam inhalation. We should go for some honey-based syrup prescriptions, which does not contain a lot of toxic substances. We can go for a plain honey syrup. In India, we know honey test is very famous. We can go for that. Menthol-based syrups, which have honey in them, they're really good for supportive measures. And I think the main communication would be with the parents that if it is not infective, it shouldn't be treated with antibiotics. If you explain parents that these antibiotic will cause harm rather than benefit to their child, I don't think there would be any parent who would be willing to cause harm to their children. The third E would be to give them a written kind of thing or mention somewhere in the prescription about the red flag signs. The parents should be very clearly told when they have to come back, what they should look for, what can be dangerous to the child. and they should be told about a certain timeline. Yes, it will take a week to resolve. Do not, judge, do not rush, do not doubt your physician. We know it, we're there for you, but it will take time. It's not
Regarding
the
empowerment, okay, I just recollect in 2020, roughly when we started our COVID webinars, okay, Krishna, our founder, chairman, trustee, he mentioned very clearly, whenever a COVID patient come to your office, we don't know anything to treat, particularly in April, May 2020 kind of thing. No guidelines is there, just a supportive care. So even if the patient doesn't have any major issue, please give him a paracetamol. Please ensure that enough hydration, or some other things. With empathy, you talk and then give something that would work. So that's what. So I just
So I would just add a few things, ma'am.
please.
So in India, the things are slightly different in that sense that you have three types of patients. I'll be very clear in pediatrics. One is the category of patient who is not going to give even a simple anti-allergic or any cough syrup without the doctor's recommendation. I think that would be about 5% of the patients. Then there would be a big majority of patients who would be taking the medicines either from the quacks or from the local doctors, or would be giving themselves. Now, themselves, I think COVID had empowered them enough to give azithromycin as a cough syrup. You won't believe, but I have patients who have told me, "K, I've been giving this azithromycin thrice a day, and इसकी खांसी नहीं ठीक हुई." And I was like, "Thrice a day क्यों? ये तो cough syrup है ना? आप एंटीबायोटिक बताइए कौन सा देना है, कॉफ सिरप तो मैं दे रहा हूँ ऑलरेडी." So you won't, I mean, this is the kind of situation. And the third category, obviously, we have where we write a prescription, and that prescription is being used by the patient for years to come. So I've had patient whom I gave a prescription in 2021, and I think day before yesterday I had that patient who came to me with the same dose of clarithromycin he was giving to the child, and now the child is about 10 years old. So वो जो 6 साल पे लिखा था वो 10 साल पे भी वही डोज पे अपना लगाए जा रहा है, करे जा रहा है. And another thing he told me was that now I give that just for 2 days, and the child usually gets well. This time, the situation has been that the child has not been responding. So what I want to say is that the main issue is the antibiotics being easily available in our country over the counter. That's my main issue, and that's the main issue, which is I think the reason why we are having this seminar or this CME today is like this has become a big issue, because at the end, when something goes wrong, everything comes onto the doctor. But we need to understand what that parent or what that patient has done already. So if the patient was already given a 3 days of antibiotic, tell me one thing: how do I decide whether I need to give a fresh antibiotic or whether I need to continue that? What should I do? I mean, it may not sound logical to give, but what should I do? That's the problem.
See, quickly, don't go. So please let us know what is the outline. Can you outline the current legal framework governing contamination, quality control, and manufacturer accountability in India?
Okay, so if you go by the simple thing, accountability, so as far as the manufacturer's accountability is concerned, it can be both civil as well as criminal. That is there. And in case there is adulteration, there are very clear guidelines that it can be criminal at times. But now the issue is that it is very difficult to really prove a lot of times, because the samples, the standardized samples and everything, now we know that this thing happened, but it's very difficult to prove if it actually happened because of those syrups. See, the legal frameworks work in a very different way. What if those children were also given another set of medicines? So somebody can see, as a lawyer, they're going to have a very different kind of an approach. They're going to save their own clients. So the rules are definitely there, but the liabilities, if you see, more or less, it becomes difficult to prove later on. So what is important is that the rules which are there, or the guidelines which are there, those people who are doing the pharmacovigilance, they have to be more honest towards their working, and probably prevent such kind of incidents. Because once these incidents happen, it's almost impossible, because when they say that, okay, we have collected those samples, but they're going to bring in, say, hundreds of another samples to prove that doesn't have the diethylene glycol. So how do we prove that the same batch is going to have a different thing? So these things are very difficult in India to prove per se, because we know at every point of time we have leakages and we have issues. So I think legal framework is quite clear. We
But what has
legally
happened?
speaking, law के हिसाब से everything is good, but the law has to be implemented. The implementation is pretty bad.
No, I agree with you. But again, it is, as per law, it is accountable, and then criminal negligence can be claimed. And then Drugs and Cosmetics Acts, Section 26A and 27, as per BNS, okay, prohibit.
So that's what I'm saying.
Up to life imprisonment for adulterated or spurious causing harm, plus additional charges will be levied on.
Absolutely, these things are there.
And
these things are there.
Will also be
but the main
cautious because it has costed lives.
Absolutely, but then how many are able to do that in our country?
Discuss here. Let's not deviate too much. I'm sorry, but I agree to the points what you mentioned. So again, can I call upon Sakshi? So, what clinical red flags should pediatricians? You mentioned very before, when cough is not going, what clinical red flags you should warn your what do you call pediatric patients and their families. But what clinical red flags should pediatricians watch for diethylene glycol toxicity, which has happened in the current tragedy, whether it is neurological, renal, or hepatic, and how do you handle quickly?
Am I audible, sir? Okay.
Yeah.
So I would say the red flag triad would be to have altered consciousness, abnormal breathing, hepatomegaly, jaundice. We definitely know this is syrup on intoxication in most of the cases where they have a history of syrup intake. So I would say the response is usually multisystemic and it's really rapid, especially in infants. And the neurological red flags are the earliest to come and they are the most lethal. So CNS depression, paradoxical excitation, lethargy, drowsiness, shallow breathing, cyanosis, they are all like red flag signs, neurological red flags, which need to be dealt immediately. And in most of the cases, we think it is codeine, dextromethorphan toxicity. And if the child is having seizures, tremors, agitation, hallucination, we know it's some sort of pseudoephedrine antihistaminic overdose. And if the child is having ataxia, confusion kind of symptoms, we know it is mixed ingestion or some alcohol in the syrup. We know about it. And the child, when it has like pinpoint pupil, we know it's some kind of opioid we're dealing with. Mydriatic, we know some sympathomimetic drug has entered the body. The cardiovascular symptoms would be tachycardia, hypertension, sometimes arrhythmia, bradycardia, hypotension, and acute abdominal pain. And I would say jaundice, hypoglycemia would be the signs where we think that liver is not working. And with the symptoms of oliguria, we know it's kidney and probably dehydration.
So anything which is not normal, we should alert them.
Very cautious.
And then, come back to you and then come for a review. So coming to Dr.
In pediatrics, I'll tell you, in pediatrics, we always say if the mother is saying something, that something is wrong, even if you think that the child is well, just accept what the mother is saying and try to find out. I mean, it's a very straightforward.
Very valid point. So coming to Zaheer. So Dr. Zaheer, in an age of social media outrage, how can physicians respond responsibly, balancing transparency without fueling panic? Okay, in the current scenario, quickly in less than 60 seconds, your response.
So the physician should respond with evidence. There should be a rational use of this, whatever the cough syrups are there, and it should be evidence-based and scientific practice should be there. And the patient education or reassurance should be carried out. And as I have already spoken about, the drug-to-drug interaction and abuse potential should be explained to the patient. And the difference between use, misuse, and the abuse should be explained. And we should be more vigilant against this misuse. This is my take, I think.
Thank you, sir. So, Ravi bhai, should clinicians share partial accountability when they prescribe unapproved or irrational syrup combinations? 60 seconds for you.
Sir, we have to be careful. Vibhu told it very carefully. It can be there in the market, but be careful as to what you are prescribing, even if it is available. We cannot take things lightly कि है तो हम लिख देंगे, ऐसा नहीं है. That approach won't do, because ultimately, as we are seeing that we are a part of the system where we will be held accountable even if we are not the people approving for it. So I would just say that we should practice with care. We should know what we are prescribing and to whom we are prescribing.
Excellent answer. So, Aditya, what is the ethical approach when a worried parent asks, Doctor, okay, you have prescribed this syrup. Okay, is this syrup safe for my kid? What is your comments? How do you handle?
Definitely, sir. When such controversies are there, whether it is around some drug safety or some cough syrup safety, or whether there is something related to medical error or there is some systemic failure. So usually patients attendant do come to us with some fear, or there is some confusion regarding the drug, or there is some mistrust relating to doctors. Then there are so-called some national leaders, or whether there are so-called media where they are giving some false narratives in the market. So ethically, what I do is first to listen that patient or attendant without any defensive. It is very important to correct the misinformation, and then again, it is again very important is to rebuild the trust, because I approach such conversations with very transparency and empathy, which is very important. That to acknowledge their concerns as valid first, and then I make a very clear distinction between whether what is correct, whether this cough syrup is safe or not. Evidence-based guideline I just provide to them, and I just make a clear distinction between any evidence-based guideline and some media-driven narrative. So it is very important, sir, to provide an accurate and balanced information, clarify what is right and what is wrong, and very willing to be revisit whether the decisions which we have taken earlier, whether it is right or not, whether if I prescribed a cough syrup, whether it is right or not, whether it has make any mishappening. So
Thank
the
you so much.
priority should be we should be individually clinicians should be approaching to such matters, and we should be staying calm, being honest with the relatives, and prioritizing the patient autonomy, which is very important in allaying such fears or any concern.
Thank you. So, over to Dr. Rajiv. As a pharmacologist, what changes do you want to see in testing, regulatory oversight, and pharmacovigilance to avoid another tragedy?
Yes, sir. Actually, the first thing is we have to have patience, because suppose a new drug is coming, we are focusing on the good lab practices, good clinical practices, but we are like ignoring sometimes good manufacturing practices and good documentation practices. So I believe that we have to go for the quality controls with ICH Q2 and Q4 standards, and the ingredients like excipients should be properly, monitored. And the post-marketing quality surveillance should be more focused. And there some regulatory bodies, focusing on the documentation practices they are following or not, the manufacturing practices, whether any contamination is there, like just to check, because like Diwali is coming and adulteration is everywhere. You can see in paneer, you can see in everywhere. So adulteration is there in the drugs also. There are many things we see, like common sattu and basins are present in a common medicines also we see in news reports. So proper, I think, quality checking should be done to check, the further. Yeah.
Thank you, Dr. Rajiv. So now I'll quickly move on to the next round. And after finishing this round quickly, probably next 10 minutes, we have to wrap up. So, Vibhu, should there be universal labeling code for these pediatric and adult cough syrups? And what is your thought process of such harmonization across the globe?
So definitely, yes, there should be a strong and a strong thing that the global standardization should be there. And the reason is that we are making a lot of drugs in India and we are supplying to the different countries. So it's just that we are getting drugs from the different countries, and we are also supplying to different countries. So we need to have some standardized procedures and standardized labeling, which can be it should be very clearly mentioned what are the age restrictions which are there. The dosing could be mentioned. what are the contraindications, if that could be mentioned. With the help of a QR, we can have a kind of a QR, a standard QR on the cough syrups, or even the other drugs, that which can give us the information about the expiry dates, the manufacturing dates, the contraindications. The excipients should be very clearly mentioned.
Right.
Because as Dr. Rajiv also mentioned that what are the different, because as you also had mentioned that there are syrups which are there in the market which are supposedly Ayurvedic, but they use a lot of other excipients. So everything I think should be very, very clearly mentioned. And nowadays it's a thing of the digital world. So we can just have all the information, the entire information can be with the help of a QR code instead of having those inlets. Because if you see, most of us who get these inlets, I think they are not readable. So
Right.
if you get it in the form of a QR and you have the standardized labeling of all everything, so then you have and that standards should be there in the world. It shouldn't be that in India a particular molecule is banned below 2 years of age, while in US you're giving it at 6 months of age. Let's be very clear on that. So we have a very much a different kind of practices. So we need to have a standardized thing across the world, so that wherever you get it in India, or you get it in UK, or you get it in US, you may not get that molecule in India, but once it's available in India, the thing should be it's standardized for this particular age of this particular weight, and this is the dose. So that should be a standardized thing.
Thank you, Vibhu. So, Dr. Sakshi, see, how can UK pediatric dosing frameworks guide Indian prescription norms? Okay, quick response from you.
Yeah. So one thing which we should follow from EU guidance is that EU guidance very clearly says avoid multi-ingredient syrups. We should avoid too. We shouldn't be giving the whole cocktail. If needed, go with the indication. Do not and go with the age cutoff. Do not go with the whole cocktail. That would be one thing. The other thing would be, I would say, as Vibhu sir also mentioned, that you can do some QR code system from a doctor's point of view. What we can do is we can do some QR code where they can read how can they treat cough without antibiotics, or with what syrups, what is allowed in children, what is not allowed in children. We can standardize the drugs like dextromethorphan, codeine, first generation antihistaminics. They are completely blacklisted below a certain population, like below 6 years of age in UK. What we can do is we can do the same in India. The major concern is availability. So everyone wants a quick fix. If I get a quick fix, I'll do the quick fix. If I get something over the shop, why would I go to someone who takes money from me?
Right.
So what we can do is we can avoid the over-the-counter thing. For that, we need to stop that to be sold on. The UK do not sell anything over the counter. So all you can get is honey. No matter if you're dying, you have to go see your GP. If your GP prescribes, then only you get it. I am myself a food allergic person. I had to go to my own GP being a doctor to get my adrenaline prescribed. And then also they were asking for 100 evidences. Why should I give you adrenaline? I said, I'm a doctor. I won't abuse my adrenaline. But then you have to go through a process.
Strict
It shouldn't be
regulations and
easy.
putting the regulations into practice, what is important. Really appreciate for that response. So, Zaheer sir, so I think in the previous round we have discussed your question, that is pheno and eosinophil count. So, any quick comments? 30 seconds.
The only thing is that you have mentioned about this, there will be zero increase and zero decrease will be fast decrease in the pheno levels. So as you have said, that will be in the increase will be in the GARD, and the decrease will be fast decrease in smoker or in viral infection. That should be taken care of. Only thing is that
Thank you,
from
sir.
my side. Okay.
And Ravi bhai, does refractory chronic cough deserves its own ICD code? Okay. Is it time to call it as a disease, not a symptom?
Sir, I feel it is an extension of or a percentage part of the diseases which are already there. I really don't think that we need a separate classification. We just need to evaluate current diseases more extensively, sir. That is what I feel.
Thank you so much. Aditya bhai, how can pulmonologists practically adapt treatable traits model in high volume outpatient setups? Quick,
Yes, sir,
overall,
because, sir,
I am looking for a drone's view in 30 seconds.
yes, sir. Because, sir, in India we have a very huge volume of patients with whether there in these patients there are various phenotype overlap, and the diagnosticity is also very uncertain. So in such patients, basically in my practice, what I do is I have a basic trait checklist which is integrated. I have also made case sheets which are there, and I simply tick down all the things which are there. Like I take a detailed history, and by that I always see first I clearly modify into the modifiable traits, and then I clearly divide. For example, if a patient is there of chronic cough who have airway inflammation, so directly going for a cough syrup is not a solution. We can go initially go for a eosinophil count, or we can go for a pheno testing, and then accordingly we can treat it. If a patient is there of asthma or COPD, I check for traits like whether there is a non-adherence, whether there is a poor technique, whether there is some anxiety, obesity, and so and so. So ultimately, the treatable trait model gives us a way to practice precision medicine in a very pragmatic way, because we are not focusing on the labels, we are focusing on what we can actually treat.
Thank you, Aditya Bhai. So coming to Dr. Rajiv, so now it is a generation for AI. Everywhere you cough, you sneeze, you have a chest pain, whatever it is. In medical systems are all okay. The data driven. So can you please add your views on how best that we can use the latest technology? Is there an evidence of AI based cough monitors? Any other novel mucoregulators or smart syrup formulations that is expecting in the future? Over to you for a 60-second response.
Yes, actually, AI can do wonders. We are still in a hope for a smart syrup, but some methanol-based and honey-based syrups, the common ones are to be used in more frequent than for global trends again. I can't speak on more on smart syrups, because there are one TRP M8 pathways we are focusing on. That is a very unique. We can go for some peripheral sensitizers also, like levopropizine drugs, which are already present, and P2X3. We can go for more on such molecules because it's acting on the nociception. So I think more research can be done, but still we are lagging behind, I think.
Fantastic. But I just want to add, Rajiv Bhai, for this question. AI-based cough monitors has become available over the some smart applications. What they do is it asks the patient to cough. Okay, if we generate, so that is a dry cough. Okay, based on which it gives differences, and then productive cough, and then woofing cough. Okay, so many things. Okay, it can based on the cough quality. Okay, it is going to give you a lot of information. It is going to diagnose the patient symptom, whether the patient cough belongs to asthmatic cough, wheezy cough, or COPD cough. So many. So there's a lot more in the A.
No, I think that kind of a screening was already there for the urine.
It is.
So now you just extrapolated it to cough.
No, it is there. Okay, you have it available in
Yeah.
India. Okay, coming to take home pearls. Okay, quickly. So one line conclusion from you, Vibhu.
So we need to have, the kind of thing that first we need to develop the trust back to the patients. And for that, there has to be a combination of industry, the pharmacovigilance people, and the doctors themselves. So we have to get back the trust, because the kind of mistrust in medicine, it's not only about this case, the overall mistrust in the medicines which has happened, that has to be restored amongst the patients, and that would require a lot of efforts. So as I say, कि वो Krishna code हमारे को लेना पड़ेगा. So Krishna Anna is taking everybody together, right from the north to the south to the east to the west, and वो सबको साथ लेकर चलते हैं, managing so many people. So I think we need a kind of a leader who can kind of manage these things and put across. So as I said, somebody had mentioned political people have their own whims and fancies. So we need to have a more positive approach, because that's the only way to restore trust. Earlier, the patients had mistrust only on the doctors, but now even on the syrups and all, it's a really bad thing, at least for our profession.
See, thank you, but I partly agree, partly don't agree. So it is not a generalized statement where lack of trust, but the problem is you see with your legal eyes, but definitely clinicians should also be very cautious. I agree with to that part, but again, so mistrust is a something which develop based on your behavior consistently if it develops as a pattern. But otherwise, so we should always, once we ensure that our availability and then our way of response attitude along with the response should be empathetic, then probably mistrust is not a problem, okay, in clinical practice. Dr. Sakshi, okay, your conclusion point?
I would say, sir, first of all, I think all our patient need is time, trust, and honey. And we should make our base more non-pharmacological, like honey, saline, and glycerol type of stuff. If we are doing something pharmacological, we should have a concrete basis. I don't say we shouldn't give syrups beyond age cutoffs. I don't say we shouldn't give antibiotics. We should definitely, we are there to do that. But it should have a very clear-cut indication. That's it. I would
Thank you. Dr. Zaheer?
Yes, sir.
Any conclusion from your point, your perspective?
So we are having a huge responsibility of carrying out the patient awareness program. Definitely, we can take the help of social, print, electronic media, and radio, TV programs we can carry out. And there should be a stringent regulatory law for the pharmacists to curb the OTC sale of these products. And last but not the least, the cough syrup, definitely cough syrup relieves the symptoms, but every cough do not need them. That's my take last point. Thank you.
Thank you, sir. So, Dr. Ravi?
Sir, refractory cough and chronic cough, you can only suppress them. Just try to concentrate on those coughs which you can actually treat and cure, like tuberculosis and other infectious diseases. Then I think at least you can make 98% of the patients happy.
Oh, 98 score is great enough, to be honest. Right. That's brilliant. Aditya?
Sir, seeing the today's scenario, sir, chronic cough deserve more than a simple bottle of syrup, which I think, in my perspective, I think we should set up a cough clinic in our, if it is possible, we should train some persons with us. We should set up a proper cough clinic so that we can counsel the patients regarding the cause of cough, whether it is a psychogenic, whether it is an organic cough, or whether it is a some associated with any disease or something like that. Because it is very important to understand by general public like why there is a cough, because usually there is a lineation towards a cough syrups and going towards quacks and taking all these things. So identifying these things will be very important in the future perspective, because now the guesswork will not be there, the precision should be more, so that the behavioral therapies are more and more inculcated in such things.
Thank you, Aditya. So, Dr. Rajiv, your take-home point?
So I think I should focus on few points only, like all the drugs should be enhanced by biotechnology and AI. They should have proven clinical efficacy. They should have a trackable dosing ingestion data. They have a proper QR code for global safety standards. There should be trackable dosing, like ingestion data also. And we should look for more and more receptors like P2X3s and TRPM8 agonists. So that's all from my side. Thank you.
Future is very promising. So every great things, beautiful things comes to an end. So it is my job to say the closing remarks. So absolutely, for the past 2 hours, I have learned so much about managing cough and then responsibly using the cough syrups and so on. So first of all, let me really sincerely thank the entire core team of CCI, Dr. Krishnana, Narayan Pradeepa, Ashish Dubey, Anil Maske, Atribai, Shivani, Tirath, Agam sir, Ravi Dosi, and then my beautiful entire panel here. Okay, for the past 1 week, you have read so much to deliver the best to the CCI audience. And thanks 1600 plus logins for this webinar. Really, kudos to MEGHMANI team for bringing in so many logins. And the entire technical team, Amit Bhai, Vijay, they work relentlessly to make this webinars a huge success. And my conclusion is, cough, generally, we may dismiss as a trivial symptom. It is actually the lungs or the respiratory system is giving a signal that something is going on wrong. Or maybe sometimes the nervous system, as in cough hypersensitivity syndromes, okay, it is telling us that something is abnormal, and it is very, very important to treat cough with a lot of dignity. And the recent tragedy reminds us safety is not optional, it is scared. It is very, very important. So, Vibhu and so many others, they very clearly mentioned, we have to be very accountable. It is, we cannot say tomorrow that the contamination is because of okay, companies' default or manufacturers' problem. It is our accountability that is very, very important. So we must demand quality assurance. As researchers, we must push for neuropathic innovation, and as an educators, it is our sole responsibility to educate the public regarding what is the myth and what is correct to implement in practice. Let's this discussion mark the beginning of a national-wide movement forward, rational, evidence-based, and ethically governed cough management. With this, I'm signing off. Next week, CCA is bringing in new series of webinar, that is lung transplantation series, and there's a lot of good. Probably we are planning close to around 10 weeks webinars on lung transplantation. Will join you there. Thank you, one and all.
Thank you very much. Good night.